his postgraduate training in psychiatry at CMC Vellore and worked there as a lecturer till 1991. Then he joined Government Medical College Thrissur in 1991, where and served as professor and head of the department for more than a decade till retirement in May 2020. Then was active in community mental health research and service development during his career as a medical teacher. Then scaling up of dementia care services through outreach services was made possible in Thrissur district through community-based research and engagement with the social government. Then took the initiative to build research capacity among the faculty and trainees of GMC Thrissur and was a chairman of the Institutional Research Committee and also the member of the Institutional Ethics Committee for many years. It is a recognized PhD guide at the Kerala University of Health Sciences and had supervised many postgraduate trainees in research, was the national chairman of the Geriatric Psychiatry Specialty Section of the Indian Psychiatric Society and currently is the national chairman of the Community Psychiatry Specialty Sector of IPS. He was a guest editor of a special supplement on dementia brought out by the Indian Journal of Psychiatry in 2009, and he was the president of Indian Association of Geriatric Mental Health, a multidisciplinary organization affiliated to International Psychogeriatric Association, and has received awards or fellowship from National Academy of Medical Sciences as well as Indian Council of Medical Research for contributions, and is a member of 10/66 Dementia Research Group since its inception in 1998. So for taking up the session, I request Dr. Shaji KS. Sir, please.
Yeah, thank you. I think there was some problem with the audio. I do not know whether that was problem with my laptop. Anyway, we will start with this program. Welcome to all participants. I had wanted this program to be interactive, so there is some case which we can discuss. Before that, if some of you could introduce yourself, that would be great. I am sort of retired, but working after re-employment as Dean Research. Most of my work had been in dementia and late life depression. I'm a psychiatrist by training. So if you have anything in particular which you want to discuss during this session, please note down or put it in the chat box. Then you can also stop me anytime and feel free to clarify things. And what would be the plan? And someone would be presenting a case, or someone wants to ask few questions or suggest some areas where we should be talking before I really start off. Who is coordinating?
Yes, sir. There is a case presentation.
Yeah. Before that, this is about mental health, and I am speaking to you mainly because mental health problems are fairly common in palliative care settings. That is the main reason. Second reason is that, unfortunately, most people do not have very clear-cut understanding about mental health. The awareness about mental health problems are not very good, even among literate, educated people, even among doctors. So we start with the disadvantage of not knowing enough, one, not knowing things correctly. So I would want to clarify that during the introduction, after which probably we'll go on to have the case discussion. Before that, you could make some comments. Anyone, please?
Good afternoon, Dr. Shaji, Sripriya this side from Pallium, India. We had a short chat hours ago. Actually, I believe this session would have come as a surprise to our participants who are like used to having PPTs shared and then reading through the PPT as the speaker speaks. I can completely make it out from Miss Indra's smile. Yes, this is going to be an entirely different mode of interaction because Dr. Shaji had specifically said he will not be engaging any PPT. He wants the session to be interactive. Our only limitation is that we are sitting at different places using different platforms, but Dr. Shaji specifically, and we also would like to have this session as very interactive.
Yeah.
So
Yeah,
that is the plan
I
for the
thank you
day.
very much. I think, let me put it this way. I took that liberty of being a 66-year-old person, retired, having spent most of my life providing mental health care. Let me put, uh, or let me put my impressions about mental health clear. One is that many of you, or some of you, might think mental illness as one problem. There is one unitary concept which is widely prevalent among the community. When you serve people, they think that mental health means something, and often it means one thing. That's absolutely incorrect. If we know that we can have diabetes, hypertension, it's as much different as these two. So I can have schizophrenia, I can have delirium, I can have bipolar disorder, I can have obsessive compulsive disorder, panic disorder, or there can be disorders. Then I can have states where I'm worried and suffering because of symptoms. Like I can have chronic backache. I'll suffer from that. But then to call it as a disorder, it might become difficult. So there are mental health situations like that. I will ask some questions and try to answer myself. How common is mental health problem in the general population? It's that about 1 in 8 might have a mental health problem among adults. What is the commonest mental health problem? Depression is the commonest mental health problem. What are major mental health problems? Schizophrenia and bipolar disorders are rare. It happens to less than 2% or even 1% of the population, but they are much more severe in severe illness than, say, depression. After depression would come anxiety states. There are other disorders. So anyone who wants to provide intervention, psychosocial or otherwise, should be mindful of the issue that when you are to provide intervention, you should be very clear about what you are dealing with. You can't provide treatment for diabetes when I am suffering from hypertension, for example. So that much has to be clear. It's not that mental health is something very amorphous, not very crystallized. So, like I said earlier, what is the condition? Condition is called mental health problem. What is the treatment? Psychosocial intervention. It does not suit everyone. So I think this topic with the presentation which we will have focuses on certain aspects. One, I presume that most of you might want to provide interventions after assessment, but then the person might have received a diagnosis earlier. It does not matter. You have to be very definite about few things before you provide psychosocial intervention. For example, if you are providing me psychosocial intervention, this much must be very clear to you. That is, am I having a disorder which is called as a cognitive disorder? Am I suffering from delirium or dementia? Cognitive psychosocial treatments as such may not work in such situations. So we have to rule out a brain dysfunction. Secondly, am I suffering from bipolar disorder or schizophrenia or other rare psychotic disorders or not? If the answer to these two questions are no, then there could be a disorder which is neither psychosis nor delirium or dementia. So there is a greater role for psychosocial interventions. So that is precisely my point. Another thing is in palliative care settings, you are dealing with people who has a life-limiting health condition. Most often, they will be having more than one health condition. Most often, these conditions will be non-communicable disorders. Diabetes. My mother, who had dementia, before she developed dementia, she had hypertension, she had dermatological problem, eczema, she had a coronary artery disease, she had arthritis due to some autoimmune disease. So you might have a person who has multiple disorders. Maybe he is also frail. Frailty is another dimension. So all this said, let us probably, I'll take questions now before the case is presented. Then again, we will have some discussion. Is that all right with Pallium?
Yes, sir. The floor is entirely yours. As
Yeah,
you
yeah.
wish.
So this is my take, that I understand that this case is something very important. Some of the rare things should be emphasized in great detail because you cannot miss them. If you miss them, mistake them for something else, miss the diagnosis or misdiagnose something as something else, then that's a huge error which has to be avoided. So that way, this case is very important. We might want to listen to the case. I've seen the PPTs. So whoever wants to present could say that with or without PPT. I'm okay with that. You can be brief if you want.
Can we move on to the case presentation?
Yes, please.
So I'm sharing the screen.
Yes.
Shall I start the presentation?
Yes, please.
Yes. Good afternoon, sir. Good afternoon, everyone present over here. So, I'm Kiranmay. I have currently completed my master's in neuropsychology, and right now I'm getting my training in CMC Vellore. So today, what I would like to talk about is, apart from the mental illnesses that Sir has pointed out, I would also talk about the mental health in general when it comes to a palliative care setting where family members, along with the patient, might face some mental illness, mental health problems, which can be stress, etc., etc. So moving into the presentation, can you just switch the slide? Yeah. So the patient I would like to talk about is RB. He's a male, and he's 63-year-old, and he is diagnosed with a high grade glioma. Basically, high grade glioma is an aggressive tumor that is present in the brain. He started with the symptom presentation of vomiting. And whatever he's eating, he's puking out, and he's has avolition, and which means that he has no motivation in doing whatever he's doing. And he also showed frontal release signs, which is okay, I'm so sorry. So basically, he has avolition and all these kind of symptoms that he has showed, and also frontal release signs. Frontal release signs are nothing but the patient shows primitive reflexes, which are grasping, sucking reflex, which we lose after certain period of time in our life. So he's residing in Assam, and he's coming from a poor socioeconomic background, and he completed his education till class 7, and then he dropped out to become a carpenter because of his low socioeconomic status. Can you yeah. So, okay. The other medical illnesses that I would like to point out are he has hypertension since many years, and he was under medication for the past 2 years, according to the according to the hospital consultation. And then he has a history of substance abuse. He has a 5 PD per day, and he used to take 5 BD per day, and he's an alcohol user, and he also uses weed, which is cannabis, from time to time, and no other psychiatric or medical illnesses reported, both in the family and also uh, uh, to the for the patient. Yeah. So coming to the insight, basically, as I already told you, the first time he has come for 2 consultations, and later he was put into palliative care. So in the beginning, the patient has like speech, a very minimal speech was present, which later consultations completely, he was stuporous, he was quiet, he was not talking at all, and his activities of daily living, which are going to washroom and eating, walking here and there, are completely absent. And he, due to these frequent headaches and all, he started to have irritation, which I would like to point out to something else, because when it comes to low socioeconomic settings, we also have to consider why they are coming at the end point of time. So when it comes to people in these areas, especially like Assam and all, in a rural setting, people live on a basis of wages. So if they don't go for their ongoing living, they won't get wages, and they will not have food on their plates. So what happens is, these people, until and unless their activities of daily living will be completely absent, they won't come to hospital. Even for hypertension, he is on and off medication for a few years, and then he just came after he's completely uh, he's completely bedridden, and there is no other option but to come to hospital. At that point of time he came, and it was out of the hands of doctors, where the tumor is very aggressive in the first place, and he's 63 years old, and he's completely he's bedridden, and it's in the last stage of tumor. Okay. So coming to the family members started to say that he's not talking, he's just having a vacant stare towards anything that he see. He's not talking anything, and even sometimes he responds to the questions of family members, and most of the times he don't. Coming to the prognosis, when the doctors have told that this prognosis is very poor when it comes to high grade glioma, the patient was only the comprehension of this entirety is very partial, and the patient was not really speaking anything. He only knows the insight of this glioma is only partial, and when it comes to prognosis, he did not comprehend anything, because his cognitive impairment by the time itself is very high. So coming to the family members accepted the prognosis, because there is nothing else that they can also do, like taking to some other hospital. This hospital itself is very far away from the house, so even taking to other hospitals, it's helpless, is what doctors have told. So they accepted the prognosis, and they accepted for the medications, and taking care of the patient in the home itself. And when it comes to palliative care, again, the patient accepted, which he was very much cooperative with us. But the problem is, the patient again doesn't have complete awareness of palliative care. Whereas the family was very supportive with the palliative care, and they have been throughout the palliative care, they have been very active, and they have been answering very well. However, there are some trust issues here and there, which I would like to point out further. Yeah. So coming to the genogram, again, as you can see, the other thing I would like to point out is the person has been through 2 marriages where the first wife was passed away. The reasons are unknown, because we don't, I mean, the second wife was the informant, and she's very uncomfortable to talk about this. So he has 2 sons and 2 daughters, and he has 5 sisters and 2 brothers. So here again, another thing I would like to point out is even though he's the 3rd child of the family, he's the eldest son of the family. So this changes a lot of power dynamics in the house, which had led to a lot of problems that we have encountered in our palliative care when it comes to family dynamics. Yeah. Okay, as you already told a lot about Mr. RB. So basically, right now he's premorbidly. I mean, previously before the tumor and all, the person has a very calm temperament. He's very friendly. He used to talk with everyone. He also has a very positive relationship with his family members and outside people. However, and he also used to love his carpentry so much that his hobby is also carpentry, and his occupation is also carpentry, which he is very much satisfied with. Then later on, after the tumor and all, he completely became withdrawal, and he just withdrawn himself from social engagements altogether. Next. The thing is, my network is very bad, so I'm not switching on the video because again my voice will blur out. Would that be okay?
Yeah, no worries. Please continue.
Okay, yeah, okay. These all I have already mentioned. I just don't want to go into it. But one more aspect I would like to mention is both his elder sons have actually dropped out of the school. Again, the socioeconomic status has come into picture, and also his eldest son has a very stressful relationship with school. He dropped out many times, and he finally just dropped out and took up working in his farm. Basically, right now the sons are also dropping out of the school and working, and the 2 daughters are studying, but they mostly stay at home because the school in Assam, in a rural area, it's not really regular. Yeah. So these all I have mentioned earlier, so I don't want to go further. You can change the slide. Yeah, so here is the echo map. As you can see, the person has a very tenuous relationship with the religion. He has a very weak relationship with the religion. However, he has a very positive relationship with neighbors and his family members and relatives. Both wife and husband have a very strong relationship. However, there is a transition of wife's relationship with family members, which I'll mention later. And when it comes to friends, when it comes to son's relationship with the outside world, they have a very strong relationship with friends. And as I already mentioned, the eldest son has a very stressful relationship with the school, and the younger son, he's fine with the school. However, he dropped out because of the financial issues. Yeah. These all I have mentioned, they are coming from a very low socioeconomic background, and they have a lot of financial issues, because of which also they took a very lot of time to come to hospital, and which is out of control at this point of time, that they have to take a palliative care, and he came to a state where there is no other treatment for him. Yeah. Okay. Coming to the psychological overview, I want to discuss about 2 aspects, especially in this case. I would like to talk about the patient's psychological profile and at the same time family's psychological profile. Because when it comes to palliative care, what I believe is it's not just about the patient, it's about the entire unit. Because in the previous sessions also, as ma'am mentioned, that it's not only the individual, it's about the entire stressors that are involved when it comes to individual and also the family. Basically, these all, most of that I have mentioned. The thing is, when we have went to the palliative care for the first time, where he was completely bedridden, he's under the catheter and he has nasogastric tube, and he's not eating, he's completely bedridden basically. So basically, during this point of time, when we tried to wake him up, he showed a profound disorientation. He's not responding. That I had to take in the first time. I have taken mini mental state examination, which was proving that it is a very that the person is cognitively impaired when he came to the hospital. But when we went to the patient's house, he was completely disoriented, that we cannot do any other further psychological assessment, that I have to take up GCS, Glasgow Coma Scale. I don't want to get into the technical details, but it was very low. It was around 6, which is a very low score in GCS. And he is just responding to the pain, and he's just looking at people with a vacant expression, with no expression. And it's only the family members talking. He is not even looking at family members. No. No bodily movements, nothing, which had led to dependent edema also, which had led to physical symptoms. Yes, further. So coming to the family psychological status, here again a lot of power dynamics comes into play, which had led to the family's stressful environment, because he's the eldest son of family, as I mentioned earlier. Even though he's a third child, he's the eldest son of family, and now his life is about to come to an end. That again there is a change of responsibility, transition of power from one person to another person, which had led to a lot of family conflicts, and there is no peace in the family that the wife can actually help the husband. So here mostly what happens is, because of the shift, and he's staying in a family where both his younger brother is in Bangladesh, and his wife and his the brother's wife also staying in one family. The entire family was staying together. Now, because the brother is in Bangladesh, who is sending money, the person cannot take the complete power over the family after, if at all, the patient passes away. So the problem is, the wife want to take up the power here. And what happens is, because the wife want to take up the power, the brother's wife is not willing to give the power to a woman. Here again the patriarchal society comes into picture. And again, the eldest son being also working in the farm, he wants to take up the power. He don't want to give mother the power in the house when it comes to responsibilities, which is bringing a lot of conflicts within the family, which had happened, which we have recognized in the last one session, 2 sessions, that there are a lot of family conflicts, and they are unable to take care of the patient well, because of all these conflicts that are happening. And wife being a very major person here, she is going through a lot of mental health issues, where she is unable to handle the responsibility conflicts, and at the same time she is not able to give her full support to her husband at this late stages of the life. So here the mental health focus I wanted to give is on the wife a lot when it comes to this kind of palliative care scenario, because the husband, obviously, his mental health, because he's completely stuporous, we cannot really talk about it. We are not in a state to talk about his mental health. But here, when it comes to the family relationships, there is a lot of mental health issues going on, especially to the wife. Yeah. So when it comes to the physical, especially in the patient's point of view, the physical, his movement is painful. We have the doctors have suggested physiotherapy. However, there is a lack of physiotherapy for the patient, and he has he developed dependent edema because of lack of movement, which is very painful for the patient. Whenever we start moving his hands, legs, and all, he's showing a lot of pain, and he's going through a lot of pain because of that movement. However, if we don't do that movement, it will lead to more rigidity in the patient. And as I already mentioned, no activities of daily living, and also he has urinary incontinence, because of which we have given catheter and all the other things. So the psychological aspects of the patient, again, the speech is absent, he's irritable, and his family psychological health is deteriorating. Because of the change in the power dynamics. Socioeconomic status, even though they have a house given sponsored by the government, land sponsored by the government, and has a house, it is in a very remotest area. Assam itself is a very remotest area, very rural area. In that, they got a land even in a rural area that they have to go to hospital 30 minutes by taxi, which they cannot afford, which can be 3,000 rupees, like a 1 month wage for them. And by walk, he cannot come because he is not in a state of walking. Most of the people come there to hospital by walk. They walk 30 kilometers, 40 kilometers easily through walk. Now, understand the state of the patient, that they are not in a place to afford for coming to hospital. So, however, the family is very supportive throughout the process, whatsoever it is. They have been very supportive, both the brothers, wives, children, and also the wife and her children. So, when it comes to spirituality, as I already told, the patient has no faith in God. However, for the family, it's the last hope in God, which also even though they accepted the patient passes away, we are humans in the end, and we always hope that there is something tomorrow. So when it comes to wife, she sometimes denies that her husband would pass away at one point of time, but she's doing all her best. She's doing all the rituals, and the entire family is supporting that for her husband's health. Yeah. So here, what I would like to discuss are the primary concern. As I already told you, here the family dynamics are changing a lot, and there is a lot of turmoil happening in the family. So now, when it comes to who is the head of the family, that has become a primary concern in the palliative care setting here. And secondly, the other aspects I would like to consider is when it comes to the patient as a center here. Here, Mr. RB is completely bedridden with absent of motor movement, and he's completely stuporous, and there is a reduced quality of life, which is a primary concern, and how we can proceed with the further end of life scenario here. And also, the wife is losing hopes more and more, and because of the entire problems that she is facing, she's also passing through a depressive phase. I won't term it as a diagnosed depression, but still she's going through a depressive phase. So also, yeah, as I mentioned, she's already denying the fact that her husband has come to end of life stage. She's also worried about the future of the family. And the patient concerns here, unfortunately, we don't know what patient wants at this point of time. So here are some discussion points. And further, when it comes to the plans, should I also go through the plans or?
Maybe later.
Yeah, okay, that works. Okay, so this is what I would like to I like to present. So
Yeah,
thank you
keep
so
this
much.
slide there.
Yes, thank you, sir.
Yeah, before we call for other comments, let me try. Where is he from? This person?
He is from Assam. So I have worked in Assam
Where?
previously.
In Assam?
Assam, Karimganj.
Is that how far away is that from Guwahati or?
Around 400 kilometers, 500 kilometers. So it will take one
Which
whole
district is this?
Karimganj. It's in the border of the Assam. Assam and Tripura. Yeah.
Okay. I was reminded of my friend who is no more. A classmate of mine, Dr. Parthasarathi Datta, was the deputy director of health services in Arunachal Pradesh. He passed away a few months back. So he was in Guwahati. So our connection to Assam started from MBBS days because he originally is an Assamese. Anyway, there is one thing which he used to tell us. He was the deputy director of Arunachal government. So he used to tell us that he had worked in various remote districts of Arunachal. He used to tell us one thing, that what you need is only a stethoscope. If you are a doctor and MBBS, you need one stethoscope. You can diagnose most problems. You can decide what you can do. Because even though Assam is remote, there are things which we can do. And there are things which we will have to accept. So I think this case exemplifies things which we have to accept, and there are small things which we can do. Thank you for that presentation, which was very academic, I must add. Let me try to visualize this. Just correct me if I am wrong. Here is a 63-year-old person who had been working, and when did he stop working, and when did he have symptoms suggestive of current illness?
So we have diagnosed him 1 month back. So before 1 month, he came to the hospital after he stopped working after 1.5 months. So it's almost 2 months, 15 days around, he stopped working.
Okay, okay. So as you rightly said, most people from lower socioeconomic status, they give livelihood prime importance and health only secondary importance, I think. So here is someone who had been diagnosed as a fatal illness, and he had suddenly deteriorated. What strikes me is that he has problem with his cognition. It is not only that he cannot comprehend, he cannot carry out his activities of daily living and needs continuous assistance for activities of daily living. So that is a difficult situation. And who are the people who live with him under the same roof?
His wife and
Yes,
his children, along with his wife and children, his brothers, wives, and children also live. His brother is far away in Bangladesh, working in
in
Bangladesh.
Bangladesh. Yeah.
Yes.
So wife usually is not does not go for work, or is it that she stopped working because of the illness, or what?
No, no, the wife is not working. She's a homemaker by default. She's a homemaker.
Okay, okay.
Uh, yeah.
So he was the earning member, he was the head of the household. He was okay when he was working, and things were okay, and everything has collapsed now. Now that
Yes.
his brother is away, and his the primary caretaker is the wife.
Wife.
Yes.
Yes.
Is she healthy? Is she having
Uh,
any illness? She must be around 50 or something like that.
she's actually pretty young. She's around, yeah, she's not pretty young. I mean, for comparative to the uh, a
Husband,
patient,
yes.
she is around like 48, 49, because it's a second marriage. Again, she
Oh,
is
yes.
pretty young. However, when it comes to, if we take socioeconomic status into background, she is weak, we can say, because of the malnutrition. And mostly they feed the children more than they eat. So there is
Yeah,
also
yeah,
that
no.
aspect.
So generally, shall we put it like this? Once, this is very much like dementia care. Uh, what do we offer for the person and the family, or what can we? One is information and education. I think that is mandatory, which you are doing, which we are doing. Second thing is support. There could be, different kinds of support. It could be psychological, it could be guidance in managing symptoms. It could be allowing them to avail benefits which they are unaware of, whatever. Third thing is the most important thing, according to me, is a point of contact when there is an emergency or a worsening of situation. So I think what would be, whom shall the wife, spouse contact if things go out of hand? Is there something like that which we can offer them?
Yes. So basically, the hospital I have worked in is a community hospital, which was
Okay.
run by CSI as a service. So we are providing palliative care there. So here, when there is a social worker there who works for the hospital, and she goes to houses every weekly 3 days. So whenever there is an emergency happens, there is a hospital phone that only works for palliative patients. So they contact, and immediately the team runs to the house. So
Oh,
that's
that's
how it
excellent.
works.
I think so. That is the point. There is a point of contact. There is an ongoing support which is offered, which includes information, guidance, and various other supportive networking. So that is all there. Yeah, I think it looked as if the one consequence, negative impact, seems to be the family's ability to manage as a unitary unit, as a unit, because there are issues regarding power, leadership, support, mutual support, trust. Okay, anybody who could comment on these things, because I think the burden is both physical and psychological on the caregivers now, because with double incontinence and bedridden patient, you will have to really struggle hard to keep him clean and uh, fairly free from pain. Any comments on this? Because overt mental health problem of this person, the affected person, it is that he has probably something like a dementia which is due to brain disease. It looks like that, because uh, was there any periods of normalcy in the last 2 or near normalcy in the last 2-3 months?
Sir, can you repeat it again?
Oh, was he normal any time in for brief periods in the last
Uh,
3 months?
okay,
Completely normal?
in a very technical term speaking, his sensorium is actually fluctuating. Sometimes he's responding, sometimes he's completely not responding. But normality, if I have to talk, he's not
No.
normal
Okay,
all
okay.
through this time.
Okay, fine. So you can let us look at comments. What do others feel? Who should be the focus? What would be that major intervention which could help to bring peace or meaningful interaction within the family? My take is that I'm sure the therapist will be talking to people. Who are the main family members to whom you are talking?
I'm talking to his wife mostly,
Yes.
eldest son. And the brother's wife was not actually given much importance in the family also. So
Okay.
here again, she was not given opportunity to speak. Whenever if we try to speak also, it's kind of like she was put aside. So that is a lot happening that we want to work on, that thing. And rest of the children are very young in the house.
Yes.
Only mostly I only have the opportunity to work with the patient's wife and son.
Yeah, I think it is very crucial that we keep talking to both the spouses of the brother and the wife, separately and together. Uh, I don't know whether, I'm sure there will be some flare ups of problems in between. So if you could win peace there between them, then things might become better, because I'm sure the resources are limited. So any opinion on that?
Dr. Shaji, I have some comments. My name
Yeah.
is Shalaka.
Yes, Shiraga.
Yeah, hi. So I loved your question. Is what about the health of the caregiver? And I was wondering if the wife being 48, 49 years old, if she is also going through menopause, and therefore some of her uh, symptoms, psychological distress is also on behalf of the menopausal uh, phase that she may be going through. I was also wondering if her parents or her family members were ever involved to engage to, give her support during these times. And uh, um, uh, uh, what was the age of the sons?
Son is around 22 years old. He is the son of the first wife and
Okay, and
the
he's learning.
he's going to farm right now. He dropped out of the school when he's around 13,
Oh,
14 years old. So,
okay. So just moving some of the adults in the family, at least maybe even the wife, towards a trade where she can gain some confidence in earning for herself and her family going forward, would have also probably mitigated some of her stress in taking care of while taking care of her husband. Maybe not immediately, but in the near future. So I just thought about that. Her family, her parents, her psychological issues could be related to her physiological changes in her body as well, and moving the adults in the family towards earning potential in the near future.
Maybe we can stop screen sharing for some time. Is that okay? Yeah, I think this is important. What do you think? What do everyone think about relationships? What happens to relationships between family members when a common stressful problem has to be faced? For example, anything, it could be floods, it could be earthquake or something which affects everyone happens. And then there would be demands on each individual and the family unit. I think this is very commonly seen in dementia care. Even caregiving, I don't know whether I'm talking too much here. See, for example, if I am looking after my mother, whom am I looking after? I'm looking after my mother, which means that I am a son, I am her son, and then she is my mother. There is this mother son relationship, which was there before she developed dementia. For example, in this case, this man and his wife had a relationship which was pre-existing, and this person's spouse and her sister-in-law would have had a relationship, interpersonal relationship, which would have been good, bad, or not so good.
Hmm.
So relationships happen before illness comes on. So two things can happen. Relationship could become better or worse. Usually it becomes worse. So that is one thing which we may have to prevent, because worsening would mean that instead of sharing responsibility, people will be blaming each other, which is very common. So that is something, and in this case, it may be important that the physical labor is shared. May not be possible uh, to clean up by someone other than spouse or a male member. So there has to be some understanding about sharing of responsibilities vis-a-vis caregiving. That may be important. Number two, allowing caregivers to vent their feelings and, what shall I say, complaints about others or about themselves would help. It's not that it will solve problems, because most caregivers do not have any opportunity to talk about caregiving. except, Assam may be totally different. In Kerala, what would very well happen is this what I sometimes refer to, or many of us refer to as visiting professors make visits. They come and tell the caregiver how often she should be doing caregiving better, and they'll go off. That does not help. Sometimes blaming is also, I've seen this with very educated families. So people really cannot get what actually is the experience of caregiving. It is very difficult to comprehend and feel the burden of care unless you had lived in the same house for a few days or weeks. So that could be one problem. So I'm sure the brother in Bangladesh may not really know how much labor is required and how much suffering is happening at home. So that is definitely, and whenever you give instructions regarding caregiving, it will be better to have all co-resident caregivers present if possible. Or in Kerala or in our setting, we have a booklet which we hand over to them so that they can read and ask questions later on. So that's something, and it is sometimes, do you ask caregiver about symptoms of depression? I'll come back to that towards the end. It is very important. Any other comment?
Sir, I would like to tell some things like when you have told this information just popped up in my mind.
Yes.
So when it comes to caregiving, whenever the son is present, especially the eldest son would definitely help the mother. Like when it comes to as you have told, like the male, even though the wife is a primary caretaker, the son also comes in and helps his mom whenever he is present in the house. And secondly, I would like to also mention that whenever we try to talk personally with the mother, but it is such a setting where there is only one room in the entire house, so they all live in one single room with two beds, where one bed is filled with the patient and there is one other small bed, and rest of all people will be in the hall itself. So this is the situation. And whenever we try to talk with the mother, have some private time with the mother, either the son or the spouse, I mean the brother's wife, they try to interrupt with by coming, going, coming, going. So this kind of, there is no aspect of privacy that was given to the wife. And there were instances where tears are rolling in her eyes, but she can't tell, she's not in a state that she can freely speak. And also there are aspects of negligence. As I already told you, there is this dependent edema in the patient, like feet of the patient, it was swollen. So we have given a specific physiotherapy for the patient, but there is a negligence to certain aspect. I mean, it's again, this is not blaming the wife, but we can understand that the wife is also going through a lot because she's unable to give her 100% when it comes to taking care of the husband, because she herself is going through a lot in this scenario. So these are some aspects I wanted to tell you.
I think that is, everybody should take note of this problem during home visits. Usually, even we have the same problem especially when someone like a medical team, palliative care is at home. Everybody in the family will be tuning in to see what is being spoken and said. Even the neighbors, they might also become very curious. So this is a problem. I do not know how to address this, but then repeatedly trying to do this and requesting people to stay a little away for a period of time might work, but I'm sure then I've ever had very similar experiences. For example, I was talking to this older couple, one of whom had dementia, and the spouse who was also old. And then I could see the daughter-in-law who was there. Actually, she was washing clothes. She will once in a while will come in and then go, as if to pick up something or something like that. And older people were saying that things are quite okay. And after few sorties like this, the caregiver told me, "Can't you see the situation?" Like that, they made some comments. So everything is okay. Can't you see that? Something like that, she said. So I'm sure. See, the issue is, will the others may think that will the caregiver blame me for not giving enough support? So that kind of mistrust will be there. So if you keep what we recommend, we keep talking to everyone. We offer them opportunity to talk. So otherwise, only one person talks to the doctor or palliative care person. She would, she or he would be considered as the person who will create impressions about others. So that kind of it is a difficult situation. I would recommend that you give more time to the primary caregiver, but keep the son and the sister-in-law also in the loop, so that they also get chance to talk to you independently and in private. So others might respect it. It is difficult. Yes. Any other comment? What would be a warning sign in a caregiver suggesting very adverse impact on the mental health of the caregiver? If you are seeing the caregiver once in a while and you keep seeing, and then suddenly you think that things are not all right with the caregiver, what would be that warning sign? For few.
One aspect I feel like is giving up on the patient can be one major aspect that the primary caregiver's mental health is worsening.
You are saying that some kind of resigned attitude, giving up attitude.
Yes.
Yes,
I
yes.
mean,
I would
not
think that,
caring anymore.
yeah, if that person consistently looks less cheerful or more unhappy, more tearful, and complaints of loss of appetite and sleep problem, every caregiver, please ask about biological functions. Every caregiver, you must ask about how is your appetite? Are you eating well? Are you sleeping well? And are you crying more frequently than before? Because crying, having significant insomnia, having complaints of tiredness, immediately should alert you to the possibility of depression, which I'll briefly discuss towards the end. That's very important because we have had suicidal attempts by caregivers. Sometimes this can be precipitated by a blame or blaming by others of not looking after the person with illness. This has happened to us. When one person with dementia fell down and had to be hospitalized, some relatives said that maybe the wife would have pushed him. and that is why he had fallen down. And he went to the hospital, got discharged, and came back. This lady attempted suicide because she said, I can't, the work is taking everything away from me. I am no more energy, but then this is too much to handle, she said. So I think that is suicidal ideas, depression, significant insomnia, significant tiredness is something which you have to look at. Yes.
So I have a question.
Yes, sir.
Generally,
Yes.
when it comes to diagnosing depression and all, uh, tiredness can be, at least we can know that there is a boundary that. But when it comes to aspects like palliative care, where the primary caregiver has a lot to do on her plate, and then how do we, where can we draw a boundary that it is a significant tiredness? So how do
Very,
we
very
know?
good question. I think tiredness is fairly a common symptom and a common complaint, especially in people above the age of 30 or 40 or 50 years. But then excessive tiredness as complained by that individual, and that is a change from the recent past. That is when you suspect that this person is become very slow and tired. It's not easy. I fully agree with you that fatigue is such a common symptom that uh, if coupled with unhappy mood, insomnia, another thing I would strongly recommend that most of us do not know that how to elicit loss of interest. Loss of interest usually coexist with tiredness, fatigue. So, if any one of you could, not people trained in mental health, how do you elicit loss of interest, which is pervasive? Because two things we should be apart from tiredness. Tiredness is unlikely to be present without two symptoms. One is pervasive loss of interest. Second one is dysphoria, unhappiness, pathological uh, depressed mood. Let me repeat that. Fatigue, excessive fatigue as part of depression is very unlikely to be present without one of the two symptoms which I said, because there are three symptoms which are very suggestive of depression. One is excessive fatigue, wanting to lie down most of the time. Second is persistent dysphoria. Keyword there is persistent. Dysphoria is unpleasant mood. Third one is pervasive loss of interest. The keyword there is pervasive. So that is something which it's not easy to elicit this. But then once you comprehend what it means to have pervasive loss of interest, then only you will be able to ask that properly, elicit that properly. Do you think that it is possible, or do you try to do that? That's what I'm trying to ask you. I'll tell you how you should elicit that.
Yes, sir. Yes, sir. Definitely.
Does anyone want to, loss of interest? See, today I'm not interested in going for movies. I see something like that. I might lose interest in movies for some time, but I might want to see football match. So that's not really loss of interest. Let me try to define this. loss of interest, by loss of interest in inverted commas, we are referring to loss of interest in things in which the person was very interested in the past. So, loss of interest means that not that at the moment I am not interested. I was so interested in this, but I have lost interest in that now. And loss of interest is pervasive because it does not confine to one interest. It is affecting all my interests. So I'm not interested to get up from bed. I'm not interested in talking to people. I'm not interested, or I'm not that much interested as I was before in reading newspapers, seeing television, talking to people, many things which all of us are interested in day-to-day life. That interest has come down significantly. That is loss of interest. And if you take a 2 week period, most of my wakeful hours, I have loss of interest. Meaning 4 or more days in a week, I have significant loss of interest. So then you qualify for having loss of interest as a symptom. Similarly, dysphoria. When I am awake without any reason, with reason, obviously, I become very unhappy. Without reason, also, I remain in an unhappy mood. Most of the time in a day, most of the days in a week, prone to tears, prone to unhappy mood, crying, with smaller events, which are unhappy events. So, if you have persistent dysphoria or persistent loss of interest along with tiredness as a complaint, then you should ask for other symptoms of depression. I'm sure. Yeah, we will get you some material on how to ask questions, which has to become very, sorry, what shall I say, routine. Because I am trained in psychiatry, it comes automatically to me. Just like a checklist. Without looking at any checklist, I'll keep on asking things. First is we must ask about insomnia. Insomnia could be, of course, this is too basic. Many of you might know. I might have difficulty to get to sleep. That is called as early insomnia or earlier part of sleep. I have problem in getting to sleep. Then uh, less common, I might get up 2 or more hours earlier than my usual time and wanting to sleep, but not getting sleep. That is early morning awakening. Then I might have intermittent wakefulness in between. So any caregiver reporting early morning awakening and then feeling very unhappy early in the morning might be suffering from a major depressive disorder. That is my take. And feels worse in the morning. So, worsening in the morning, significant insomnia, loss of weight leading due to loss of appetite. So, if you see people losing weight, looking very tearful, ask for insomnia, and then if you think that they have symptoms of depression, get someone to assess them, and then you might want to consider antidepressants there. Otherwise, keep talking to them. Any comments on this identification of depression and then allowing people to discuss? These things will have to be repeated whenever you see someone looking very unhappy. Just this checklist: sleep, appetite, slowness of movement, tiredness, unhappiness. and loss of interest. That is something which you must try and look at.
So one question, sir.
Yes.
Once you detect these symptoms, how do you approach the patient? Do you say that you have a problem? If the
Yes.
patient says, I don't have a problem, how can you give these medicines, antidepressants?
Yeah, very. I think that's it must be a very fairly common problem, because when you are facing adversity or adverse circumstance like caregiving, difficult situation, it's very common for most of us to believe that any unhappiness which results from the situation is understandable. So even many of us might think that this depression or unhappy state of affairs cannot be biological, it is stress related. There is a problem there. So I'm trying to impress that you can have biological depression, and it may be important to identify this. Question was that if you diagnose depression and if you think it will be helped by antidepressant drugs, and if the person will not accept diagnosis of depression, how do you handle the situation? Is that correct? Hello, sir. You asked
It's
that.
correct. That's right. You're right.
Yeah. It's something which I have got used to. It may be difficult for you, but then keep trying this. That is, you say that there is a stressor, there is a situation which requires you to be stressed and unhappy, but these symptoms are suggestive of some kind of imbalance in your brain, and these are drugs. See, one problem why people deny depression is, see, the fear that they will get labeled as mentally ill. Number two, medicines which you give them might actually make things worse. That is another common impression. For example, many people wouldn't consult me. If you see Dr. Shaji, he is a psychiatrist, and if he prescribes some medicine, that will make the situation worse. And then you will have to take that medicine lifelong and all that. All those misconceptions might be one reason. But then you can tell them that there is this option of medicine. And how do I explain to them uh, about antidepressants? For example, you must be honest and fact-based when you offer scientific explanations. So I tell them that when you have this kind of depression, anyway, is it all right if I take 5 minutes to explain that, so that you will comprehend that? You can use your language to explain that to your people. Is that all right with you, all of you? Hello?
All right with me anyway.
Yeah. See, what happens in depression due to biological dysfunction? Neurons communicate through neurotransmitters like norepinephrine or whatever, serotonin. And all human beings, we all have brain. We have brain which is made up of neurons. Neurons need to communicate to each other so that our brain functions normally. About 15% of human beings will have a transient dysfunction of their brain, which manifests as depression during our lifetime. It is a transient disturbance which might last for weeks to months. But it 90% of cases it becomes all right by itself. So most of us will not go for treatment. or will not require treatment. But then when it persists, it leads to lot of suffering. What these drugs, antidepressant drugs, do is to correct the imbalance by improving availability of these neurotransmitters in your brain. These drugs are not addictive. These drugs do not produce any permanent effects. These drugs improve neurons' ability to communicate. And once things improve, you can maintain a certain dose for a period of time, and then you can take away these medicines. You need not take it for a longer period. Might have to take it for few months. This first explanation may not make sense. When you keep on saying this, people will start understanding. And once you list out these symptoms, which like early morning awakening, morning worsening, slowness of mentation, everything, they will know that this has not happened to them earlier. So they might want to get rid of that, and loss of interest and things like that. I'm not saying that everybody will do that. We have had medicine professors, relative, entire family refusing to accept a diagnosis of depression, and then taking them for an excursion for holidays and things like that. So it's not that everybody will accept, but I think there is good reason to explain this much and offer it to them. Hope I made bit of sense there.
Thank you, sir. Thank you.
Actually, I am trying. I had a talk today morning. I had written a small few pages. It's in Malayalam. I'll get that translated into other English and then other languages, because depression is the most common thing which you will handle when you are in palliative care. And in fact, relieving somebody's depression, to me and many of my colleagues, is the most gratifying experience in healthcare. If I am instrumental in getting somebody out of depression, there's nothing as gratifying as that, because it's quite a suffering otherwise. I must say that. So I urge you, all of you. In fact, I had promised Professor Rajgopal that one thing, if you want to gain skill, that is in identification, differential diagnosis, and management of depression, and sometimes associated anxiety also. It's very, very important that all palliative care workers can pick up significant depression, significant anxiety among the recipients of care, and then be good at providing individualized, tailored, judicious care and support. I'm not talking about medicine here. I'm talking about the kind of individualized care which could make a huge difference to lives of people who are depressed and is seeking your help. It can be missed very easily and sometimes misdiagnosed also. Okay, over to you. I think I'm ready to clarify any doubt. Take questions. We have few more minutes time. Anxiety, yes. Oh, yes. Yeah, I must again. I'm actually. This is about low anxiety. Yeah. You are reminding, who is that? Shalaka Parab. Yeah. You have reminded me about my mother who had COPD and used to, there is a real, what shall I say, when you have someone very anxious, but at the same time uh, having a chronic respiratory disease, you cannot really use uh, anxiolytics, especially at night, because that will depress the respiratory efforts. So low oxygen level, you cannot use anxiolytics, which could have been of help. So I think improving oxygen levels itself could be helpful. Sometimes nighttime oxygen might help, uh, which can be provided at home. But then extreme anxiety, short, not course, short prescription or use of, say, some drug like alprazolam during daytime, 0.25 milligram, half tablet, might also sometimes help. It's a difficult situation. Avoid long-acting benzodiazepines like diazepam. Mind you, clonazepam is intermediate. It has an intermediate half-life when compared to alprazolam. I would prefer to use alprazolam on an SOS basis, as and when needed basis, in people if you need to use an anxiolytic. And you should try and use alprazolam judiciously. Don't see, one common mistake in palliative care and in general medical practice is that you tend to prescribe alprazolam at night, single nighttime dosage. Please go back and review the pharmacology. See, you are anxious when you are awake. Alprazolam, for that matter, is not a very good hypnotic drug. It does not, except in few cases, it might reduce the anxiety so that sleep might become better. But then alprazolam, you can use during daytime, very small doses, and try, avoid driving, avoid handling, machinery, for example. Otherwise, it's a drug which can be given during daytime, and give it in divided dosage. If I find someone very anxious, the dosage which I might want to give is 0.25 milligram alprazolam, half 3 times a day, rather than giving 1 milligram or half milligram at night. Very common mistake, because the anxiolytic effect lasts only for few hours. So if I take an alprazolam at night, I'll sleep, morning I'm anxious again. Whereas in COPD, if you give long-acting benzodiazepine, you might have a problem with low respiratory effort. So we might want to do that later on in little more detail. Any other question?
Dr. Shaji, if I
Yes.
could just ask one last question on this. Are there any as in, psychosocial interventions that work for anxiety in patients with severe breathlessness, other than the medication that you just mentioned?
Very, very good question. I think not only in palliative care, I think two states of mind which can be improved by psychosocial or mostly psychological intervention is one, depression, two, anxiety. Do we have, maybe in 2 minutes I'll finish that. See, if I have palpitation now, I will think that I have heart disease. But if a snake is under, if I sight a snake here in the room and then have palpitation, I know that I was afraid and thus I have palpitation. So it's not heart disease. I'll be the last person to worry about my heart when I have palpitation after seeing a snake. So a dangerous signal inducing palpitation or racing heart is normal phenomena. But what happens in anxiety is when you have autonomic anxiety, you misinterpret this as an early feature of a disease. That makes you more anxious. More anxious means more autonomic arousal. So you feed into a vicious cycle of being anxious, having autonomic, mainly sympathetic symptoms, sympathetic overactivity, misinterpreting that, becoming more anxious, becoming more, having more physical symptoms. So that's a vicious cycle which you can break by explaining what anxiety does to the body. Similarly, depression. When I'm worried, I think that no, I'm not good. So it again feeds into a vicious cycle. So by cognitively or changing the set of cognitions, you could improve both anxiety or both anxiety and depression. You asked about this. So if I, this is, that's why in third year, many medical students will think that they have cardiac problem after reading more about cardiac problems, and then when they have palpitations before exams, they think that they have the early features of cardiac problem. Once that is cleared, they don't think they have heart disease when they have palpitation. I think uh, giving good information about what anxiety does to the body and then discouraging people from being more and more mindful about physical changes of anxiety and encouraging people to be mindful about non-anxiety provoking experiences would help. That's some generally speaking. Organizers, any questions? I'll see the chat box once more. Yeah, I think identifying anxiety, it's not easy. Medicine side effect, usually it is in the initial few days of starting medicine. I agree that it is difficult to be definite.
Is there any other questions? If not, we will wind up the session. Sir, you are muted.
Sorry, you can share my email with them. Then I will try to answer questions and I'll send you some material, whatever is available in the next 2 days, so that you can distribute to them.
Okay, sir. Okay.
Just last one. There are 2 downloadable material. One is what matters in times of stress. It's a WHO material, which I'll send it to you. It's a long one, but then go by the cartoonic or pictures and things like that. That's very good. Uh, Please permit me to say this. We must learn this ourselves, how to control our depression, depressed mood and anxiety, and become, develop a skill to control anxiety. I know, I have learned, I was taught by Professor Kuruvula how to do relaxation exercises, progressive muscle relaxation. Then you develop that skill. I think it is important that all of you go through these two documents. May not be relevant to this, but then what are the psychological strategies which anyone can use? It's mostly a self-help kind of thing. I'll send it to you. Over to the organizers, please. Thank you very much for this opportunity.
Thank you, Shaji sir, for the insightful session. And thank you, Kiranmai, for the case presentation today. And thank you all the participants. See you all in the next section. Thank you.
Thank you.
Thank you.
Thank you.
ഇതല്ലേ